So welcome to our fourth session of Spine Booster webinars. This is an exam-oriented spine case presentations, and this is an initiative by VR Spine Group, VR Spine Learnings, and this is the first session where we are going to have a long case presentation. Today's presenter would be Dr. Subhanshu Bhaladhare. He's an exiting fellow from Lilavati Hospital in Mumbai, and today we have an eminent faculty with us. We have Dr. Arjun Dhawale sir. He's from Vadia Hospital and Hospital. He's a pediatric spine consultant and a very well-known figure in the spine circuit. We have our own Dr. Abhay Nene, my guide and mentor. And we're fortunate to have Dr. Agnivesh Tikoo and Dr. Aditya Kashikar, the young, eminent, and dynamic spine surgeons associated with our unit. Subhanshu, you can start the presentation. By the time he loads the presentation, I'll give the few basics that examiners can stop the examinee anytime, ask the questions, and all the people online can type their questions or can raise their hand and ask the question.
And actually, Harshal, we are going to ask questions to the other people online also.
Yeah.
So everyone, though you're not presenting, you're open to be questioned and you will need to stick your head out and answer. Assuming you're all spine fellows, the question should reach out to you.
True, sir. Yeah.
Shall I start, sir?
Yes, Subhanshu, start.
Good evening, everyone. I am presenting one case in which the patient is 18-year-old female resident of Mumbai, student, comes with a chief complaint of back pain since last 6 months and weakness in lower limb since 3 weeks and difficulty in walking since 2 weeks. Patient was apparently all right. 6 months back when she developed pain over mid-back, which was insidious in onset, gradual in progression, dull aching, continuous type of pain with a band-like tightness over the chest, aggravated by activities such as getting up from the bed, turning and tossing in the bed, and not aggravated by cough or sneezing, and not relieved with rest. It is partially relieved with painkiller, and it is associated with night pain, making patient to wake. Patient also complained of weakness in both lower limbs since last 3 weeks, which was gradually in onset, started with difficulty in climbing stairs, followed by difficulty in getting up from chairs to difficulty in getting up from bed. It is also associated with tightness like sensation in both lower limb. Presently, patient is bedridden since last 2 weeks, not associated with any radiation, tingling, numbness in lower limb. There is history of evening rise in temperature. There is history of loss of appetite and anorexia. And patient had lost around 5 kg of weight in last 1 month.
Subhanshu, from all this history, what are the differentials in your head right now? Let's go symptom wise. Night pain. What do you think about when you say night pains?
Night pain is mostly a classical feature of infection or neoplastic condition.
Why?
So in the night, in happens, which causes while when the patient is awake, the muscle are in spasm, which prevent the rubbing of the inflamed bony tissue. But when the patient lie down, when the patient is resting, the muscle spasm, the protective effect of the muscle spasm goes away, and the patient feel the pain and wakes up.
Okay. Any other mechanism? Like what else would you think of when there's night pain? Like, I mean, I'm saying basically night pain is non-mechanical pain. It's pain that doesn't happen on loading, and hence it's of a non-mechanical etiology. So in spine, you've got a mechanical etiology of problems. So disc, stenosis, facet, listhesis, blah, blah, blah. So that gets kind of ruled out once you say night pains. That's the way you, we like to think. The other explanation that you give is the textbook explanation, but it feels illogical in the spine because tissues rubbing against each other. Hip joint is okay, but in the spine, what tissue is going to rub against each other? And I mean, it feels a little bit odd. Yes. What about the other symptoms? Everything else that you mentioned, what does that lead you to think towards?
So the weakness,
weight, whatever, loss of weight.
So the loss, the loss of appetite, loss of weight, is a constitutional symptoms usually seen in a neoplastic or a infectious cases, and the loss of weight is also one of the constitutional symptoms of the infectious disease.
Basically, it's making you think of a systemic condition, not a localized condition. So the patient again had a lumbar disc prolapse, or if he had a fracture, then all these things would have been seen. So at your level, we just want you to see if you're heading towards grouping it towards the right direction. For example, very severe osteomalacia, they also present with this. They get temperature, they get weight loss, and everything. So it becomes a differential. Some of the seronegative spondyloarthropathies also present with this. But what we are trying to get you to say is that it's a systemic condition rather than a local condition. And it's a disease rather than a mechanical condition. I mean, if you start thinking on those lines, that's good enough for me.
And basically, with history taken into consideration, always divide your thought process in such a way that the usual headings, that congenital, degenerative, infective, neoplastic, traumatic. So once you take the history out of the patient, obviously, whatever history you have given us, the congenital, degenerative, traumatic part is already ruled out. So you are left with neoplastic and infective. So out of these, whether our history fits into these things. So if it's fitting into that, then obviously maybe these are the causes of ongoing process. And as sir rightly said, that whether it's localized or generalized or systemic, we can think over that.
Another exam question, Subhanshu, give me the differential diagnosis of night spine pains.
So night pain can be due to infection, can be due to neoplastic condition, and that too. Sorry. That too only, no, sir.
Then inflammatory SNSA, inflammatory bone disease, again one cause of the night pain. And when you say neoplastic, examiner always wants to hear that word osteoma.
Okay.
So always make sure that in your preferences, say osteoma first, then tuberculosis or infections, then come to inflammatory bone disease, and then come to other causes that way. Okay. Your HOPI looks quite nice. It actually tells us that your thought process is very correct. So carry on. Yeah. Any other question, Abhay sir? And
out of this history, can you localize which region of spine is involved, and how will you decide the level where exactly it could be?
Sir, I'm going to rule out with the negative history, whether it is cervical, whether it's cerebral, whether it's thoracic. Though the patient has said he is complaining of mid-back pain, so it might be a thoracic or thoracolumbar region, sir.
So you again have a one point, very good point, which is quite often missed or may not be present in some of the patient, that tightness around the chest.
Yes,
exactly.
Yes.
Yeah. Very classical of any thoracic or thoracodorsal, thoracolumbar level lesion.
Also, the patient talks of weakness in the legs, but not in the arms. So
Correct.
that also kind of starts making you localize towards a lower pathology than a higher pathology. And then weakness ahead of pain in the legs. Like if there was more pain in the legs, you would have thought of lumbar. If there's more weakness, you would thought of higher, like conus or cord level. Yeah. So it's okay to, I think, localize before your negative history based on because these are very strong points.
Yes, sir.
Okay, I think go ahead.
There is history of decreased sensation below umbilicus and difficulty in appreciating hot and cold sensation while bathing. There is no history of bowel and bladder involvement, no history of fever with chills, no history of swelling anywhere in the body, no history of any discharge or sinuses. There is no history of upper limb weakness. There is no history of difficulty in combing hair, buttoning or unbuttoning of the clothes, mixing food or eating food with spoon. There is no history of neck pain or upper limb pain.
Okay, so this history of lack of hot and cold sensation, what does it tell you?
Sir, it tells us that there is a spinothalamic tract involvement which carries the sensation of temperature, which is present in the anterior part of the cord. So the pathology.
So just say that again. Spinothalamic is present in the anterior part of the cord.
So sorry, lateral spinothalamic tract in the lateral side. So the lesion must be in the anterolateral part.
So cold and hot are carried by which tract?
So lateral spinothalamic tract. Sir.
And what about fine motor touch? Fine touch carried by which tract?
Sir, fine touch by posterior column, sir.
What does gracilis and cuneatus carry?
Sir, gracilis and cuneatus carries the is the part of the posterior column tract which carries the sensations of fine touch, proprioceptions, joint positioning, 2-point discriminations.
And which is the anterior most tract then in the spinal cord?
So anterior spinothalamic tract is there.
The most anterior in the cross section is which one?
So the most anterior will be the lateral spinothalamic tract, followed by then corticospinal tract, and then the posterior column.
Why will lateral be anterior?
So because it crosses from the opposite direction and lies anterior.
No, that's not true. Lateral is lateral, anterior is anterior, but the most anterior is still the motor tracts. They're still the most anterior. So all I'm trying to say, because even I'm not sure, because I don't need to know this, but the minute you mention hot and cold sensation as a positive history, you've opened yourself up for this entire questioning, and more than me, a neurosurgeon will really grill you down to all the wiring of the spinal cord. And it's good. You answered 80% right, so you'll get some bonus points, but you better be ready with those answers. You can't then have a shaky, if you mention these, because you can get away by not mentioning these, because how often do we ask for this in the OPD? At the level of a ASSI spine fellow, it's okay if you didn't mention this. And if someone cross-question you, you can say, I did ask and he mentioned this, but it's not too insignificant, right? It doesn't matter to the big picture.
Yes.
Got it? So the minute you go slightly off the standard track, pain, weakness, all standard. But the minute you go slightly off, you've opened up an entire set of questionings for which you can score or you can go back. So I think all of you, whoever is listening, will be well versed or should be well versed with the transfer section of the cord and exactly what happens where, exactly which fibers cross where, and which are the medial most fibers, which are the outermost fibers, which is, they'll even ask you to draw the track and ask you for the detailed of every every column.
So whenever you have a case of a myelopathy or a cervical region or thoracic region, you should prepare yourself for this questioning. You should know in detail, in depth about the tracts, the efferent and afferent tracts both, and also function, because you eventually have to localize your lesion, and having a thorough knowledge about these things are very important, as sir said. And don't get confused, Subhanshu, like this. The anterior and lateral is most anterior and nothing. That's not the case. What you're talking about is the central compression and like central cord syndrome or central compression leading to something else, and that way. So it's not lateral is lateral always. Yeah.
Yes.
Fine. Go ahead. Any more negative history?
Yes. There is no past history of contact of history of tuberculosis. There is no history of lifting heavy objects or chronic cough. No history of pain in small joint or morning stiffness. There is no history of trauma or any fall. There is no history of fever, cough, or cough with expectoration. There is no history of abdominal pain, swelling, bleeding per rectum or hematemesis.
Okay.
History of treatment taken. Patient has seek medical help elsewhere, where she was asked to do a MRI followed by a biopsy, after which she was started on a daily medications. After taking the medication, patient gives a history of change in the color of urine to an orange. On personal history, patient is
what does that tell you?
The patient is on anti-tubercular therapy mostly because the change in the color is because of the rifampicin drug.
Which
So she might be in the.
which other conditions give you orange urine?
Sir, if the patient has eaten beetroot, or if the patient has this one, porphyrias, that time the patient gives the change in the, or the patient has a bleeding through the urethra or in the bladder, that time the change in the urine might be noticed.
So just like these tracks you said about that hot and cold, just like that you mentioned about this urine color, and you have diverted your discussion towards what sir asked you the question, that which other condition, what color urine you get, or in which other conditions orange color urine you get. So while presenting your history, you have to lead the examiner what exactly you want to present, rather than they asking you or taking you away from your main topic. So even though a patient has given you this history, maybe you can keep that with you. You need not mention that in the history presentation.
Okay.
Later on during discussion, if at all examiner asks you, then you can say, sir, the patient told me that. But basically you can get away. The idea is you have to lead examiner to the topic where you want to discuss, or you want to present more things, or what you know better. Okay.
Yes, sir.
Yeah, very rightly said, Aditya sir. Basically, even if you take this history or a patient tells you this history, keep it with you. Because the moment any examiner wants to jump on this and take you towards the discussion of all the drugs, because earlier the discussion used to happen again this now we have fixed dose combinations, but previously they'll ask you, okay, so what is the schedule of the drugs, what did does she take anything in the morning, anything in the afternoon, anything in the night, and everything. So if at all examiner goes there, you should know that individual drugs and what time they were taken, which drug was taken empty stomach and everything. So anyways, antitypical.
Yeah, any other color than like coke colors urine in alkaptonuria, and what all spine changes you get in alkaptonuria or ochronosis, or so discussion goes haywire in that case. So so always lead your examiner what you exactly want to present.
Yes.
Go ahead.
Personal history: patient is non-smoker, non-alcoholic. There is no history of tuberculosis infection in family. There is no significant medical or surgical history, and there is no history of similar illness in the family. Patient is currently disabled with inability to walk, sit, stand, which is associated with inability to perform activities of daily living and going to her college.
Okay, here I would like to ask you one thing. Means later on the decision making point of view, see, person is not able to stand, sit, stand, walk, maybe because of two reasons. Either there is somewhere severe pain because of which he is not able to do that, or he has got weakness in his legs.
Yes.
So in your patient, what was the thing which was holding patient back from sitting, standing, walking?
So sitting she was not able to do because of the pain, and standing and walking she was not able to do because of the weakness.
Okay. Because these things will be important from, because that weakness, whether it's recent onset or it's a chronic ongoing thing, or later on the instability part, because pain indicates more towards the instability part.
Yes, sir.
Correct?
Yes, sir.
And the weakness is indicative of there is cord compression. So something space occupying lesion or some kind of abscess collection, or it can, so basically indicative of cord compression.
Yes, sir.
So in history only you can make out what exactly, what radiological thing you can expect just by history.
Yes, sir.
Yeah, go ahead.
Summary of the histories. The patient has an insidious onset mid back pain, which is continuous dull aching not relieved by rest and associated with evening rise of temperature, weight loss, and loss of appetite. There is a gradual progressive weakness of both lower limbs since 3 weeks. There is a decreased sensation below umbilicus. There is no history of gallbladder involvement and history of treatment of where biopsy is done and change in color of urine noticed.
You could have added one more point here, that tightness of the chest. That also is important point. Yeah. Go back. Give your provisional diagnosis here.
Sir, my patient is 18-year-old female with progressive thoracic compressive myelopathy with paraparesis with sensory loss without bowel bladder involvement. Most likely due to extradural compression, and most common etiology being infection. And I would like to keep my differential as tumor or neoplastic condition.
Okay. Explain everything. Why compressive?
So the patient is having the complaint of bilateral lower limb weakness with the tightness of lower limb, and also there is that's why the progressive compressive since 3 weeks, and that's the cause, sir. I mentioned.
Okay. Tell me the differences between compressive myelopathy and non-compressive myelopathy.
The compressive myelopathy, the patient will have asymmetrical involvement of the lower limb, and in a non-compressive myelopathy, it will be symmetrical. The onset in a non-compressive myelopathy will be sudden and associated sudden, while in a compressive myelopathy, it is gradually insidious in onset with a gradual progression. That's the main differential diagnosis, sir. The differential point. And sensory involvement is present in compressive, while in non-compressive sensory is usually absent. Sensory involvement is usually absent.
Sure, sensory involvement is not there in non-compressive myelopathy?
Usually absent, sir.
No, you mean to say something else. It's a myelopathy. Sensory involvement will be there. In a subacute combined degeneration, you don't think there's a sensory involvement?
Yes, yes. No, sensory.
You want to use some other word? Fine.
And the sacral sparing occurs in non-compressive and compressive, and sacral sparing not occurs in the non-compressive.
Okay, fine.
Compressive myelopathy you can get in sudden thoracic disc also, because you said the compressive myelopathy, one of the means the onset is usually gradual, you said.
Yes, sir.
So if someone gets thoracic disc which is significant, causing significant compression of cord, so in those cases, means by and large it can be a gradual progression, but in cases so like acute thoracic disc,
the classical teaching, sir, Aditya sir, that compressive is typically gradual in onset, but the presence of root pain or a girdle pain, as well as a zone of hyperesthesia and everything more rise that happens in like every point need not be matching, but yeah, sudden onset can happen in acute giant thoracic disc.
Yeah, which is very rare. I can understand it, but basically that can be one of the...
Yeah, but the other point, then root pain or girdle pain or zone of hyperesthesia and everything would be present. Yeah. That will rule towards the compressive myelopathy.
Correct. Correct.
Yeah. So what all type of bladder involvements can happen in a myelopathy?
Sir, in myelopathy, there is upper motor neuron type of bladder, which is associated with the filling of the bladder to its capacity, and then passing away and the patient passes urine on its own.
Give name of the symptoms, exact symptoms.
Automatic bladder, sir. There will be the increased frequency in the urine, sir. There will be post-void dribbling will be there, and post-void collection will be there. The main complaint will be the increased frequencies.
Yeah. Fine. Yeah. Carry on, Subhanshu.
On general examination, I have examined the patient in supine and prone position, lying in the bed from front, back, and side, as and when required in an open and well-lit environment. Patient is conscious, cooperative, well-oriented to time-place person, moderately built and moderately nourished. No pallor, icterus, cyanosis, clubbing, edema, foot, lymphadenopathy, enlarged neck veins or neck swelling. Vitals are stable. There were no neuropathinous markers, no trophic changes in lower or upper limb. On systemic examination, CVS, RS, and per abdomen was normal. Gait was not assessed since patient was not able to walk or stand. On inspection, midline.
Just a minute, Subhanshu.
Yes, sir.
Yeah, Agni sir, Rohan sir, both of you are online now. You can ask questions, sir, anytime. Subhanshu, just briefly give your come back to that history page, the summary of history for benefit of both of them.
Yes, sir. So, my patient is an 18-year-old female with an insidious onset of mid-back pain, which is continuous dull aching, not relieved by the rest and associated with evening rise in temperature, weight loss, and loss of appetite, and having a band-like sensation over the chest, with a gradual progressive weakness of both lower limbs in 3 weeks, decreased sensation below umbilicus, no bowel bladder involvement, history of treatment where biopsy is done and change in color of urine was noticed. And my provisional diagnosis was a progressive thoracic compressive myelopathy with paraparesis, with sensory loss without bowel bladder involvement, most likely due to extradural compression, and most common etiology being infective, most likely to be tuberculosis. And I would like to keep my differential as a tumor or a neoplastic condition.
So, Subhanshu, was this your all history or that was a summary of history?
So this is a summary. We have came till the.
It was a summary, sir.
Dr. Ashok sir.
Yeah.
Okay.
You want to grill him on a diagnosis, sir?
Can you go back to that history page? Sorry, I joined a bit late, so I just need to. Okay, fine. So did you specify that weight loss, how much of weight loss is significant? Like patient says, I was 56 kgs 3 months ago and today I am 55.
So
he did mention 5 kg loss in a month.
Okay.
In his HOPI. Yeah.
Right. So usually 10% should be is considered a significant as per patient's weight. Right. I think this. Let's move to the examination and then ask questions.
Dr. Rohan, you also contribute to the discussion. Rohan Gala.
Here pertaining to this case, I feel, how did you rule out a bladder on your provisional diagnosis?
So I asked for the patient about the complaint, whether there is any increase in the frequency or retention of urine or any other bowel bladder involvement or difficulty in passing stool or something.
So, I mean, just to have a rough idea here, like if you are saying like this is like he has tightness in both the lower limbs, you are posing a diagnosis of a myelopathy, especially a compressive myelopathy. Yes. So you will have more increased urgency and frequency. And, you have to also ask him about whether like the questions you are supposed to ask is not about retention, but about urgency and frequency. Let's just say if he was a walker. Okay, yes, you have to ask him about the fact whether he's wetting his clothes on his way to the loo or anything like that. Because here you will actually try to elicit urge incontinence, one. And secondly, one very essential point is that whether this pain worsened specifically at night. I mean, if you have an infective and a neoplastic etiology, night pain or night cries has to be,
yes, sir.
He did mention that.
Yeah, he did mention.
Okay.
He did mention about that. Yeah.
Sorry. I was not there in the history, but yeah.
No, agreed. Please carry on. Yeah.
So that is it for now. But you should be able to, kind of elicit specific questions as far as bladder is concerned to differentiate between an element bladder and a UMN bladder.
Yes.
Okay. Yeah.
Carry on, Subhanshu.
Sir, I have not assessed the case because the patient was not able to walk. On inspection, there is a midline swelling at mid-thoracic region. There is no paraspinal fullness or swelling present. Midline furrow was well maintained. Head well centralized over pelvis. Both shoulder scapula PSIS at same level. Both popliteus crest at the same level. From side, a localized kyphosis is present at mid-thoracic level. No neck, axilla, abdominal groin fullness or swelling present. Both ASIS, patella, and medial malleolus are at the same level. There is no scars or sinuses. On palpations, my inspectory findings were confirmed. There is no local rise of temperature. There is no superficial tenderness. Thirst tenderness and rotatory tenderness present at D6, D7 level. Paraspinal muscle spasm present at the thoracic level, and buckle was noticed at D7 level.
So again here,
So the movement.
Shubhanshu.
Yes, sir.
Yeah, you have mentioned about levels here now. So now the discussion will go on. Any examiner will, if they are interested in surface anatomy, they'll take you to now surface anatomy discussion.
Yes, sir.
So how you ascertain D7 or D6, D7 level? So right from top to bottom, what all the major landmarks with which you can determine the levels?
Sir, C7 spinous process is one of the most prominent spinous process. You can count down from there. Then D3 spinous process lies at the spine of the scapula, and D7 spinous process lies at the inferior angle of the scapula. You can also trace down the D12 vertebra to the D12 rib to the D12 vertebra, and then trace it down or go up. And also the highest point of the iliac crest lies at L4, L5 level. And both the PSIS lies at S1 level, sir.
Okay, out of this, only the one thing I would like to say that sometimes you may not have D12 rib. Sometimes. Yes, and rib wise also, it's very difficult to palpate or find out rib because of the muscle bulk or any fat. Okay, so rest all points, what you said, it's absolutely right. But rib wala part may not be true in all cases.
What percentage of population doesn't have a 12th rib?
I don't know, sir.
Again, you opened your mouth, that's why I'm asking. So it's 8% just for the exam. Okay, go ahead.
Sir, range of motion was not assessed because it was very painful for the patient. On neurological examination, higher function, patient was conscious, cooperative, and oriented to time, place, person. Cranial nerve examination was normal. On motor examination, there was hypotonia, nutrition well nourished, and involuntary movements were absent. In the upper limb, the power was 5 out of 5. In the lower limb, in the right side hip, it was grade 3/5. In the left hip, it was grade 2/5. In the knee, it was grade 3/5. Both sides. In the ankle, both bilaterally, it was 2/5, and the EHL and FHL on bilaterally 2/5. I have assessed the
any grading of tone.
Sir, modified Ashworth.
Can you quickly tell me the grades?
Sir, I didn't.
So you'll have to know, okay? Because say if you mention tone, you will have to know, because it's like Ashworth is like basic.
And if your grade Ashworth grade is more than 3, you may not be able to comment about power also. So you should be able to know that.
Right. Power grading is done on which scale? The power grading that you've done is what scale?
So is a MRC.
What's the full form of MRC?
Medical Research Council.
Medical Research College?
Council.
Okay. And is there any other way to grade power in tuberculosis?
No, I don't know, sir.
Specifically to tuberculosis?
So there was a grading given. I don't know the name of the person who has given it, but it was given on the basis of the functional limitation to the patient. In the grade 1, the patient is having constitutional symptoms but no neurological symptoms. In grade 2, the patient has mild neurological symptom. In grade 3, the patient has loss. Weakness, but it is functional, and in grade 4 it is non-functional.
It's Neuric's grade, and in TB you will have to know because Neuric grading is quite a standard thing for our generation, and our generation will be asking you questions, so you will have to know. And then
Neuric
also,
grading is not for the cervical.
I'm sorry, it's not Neuric. Give me a minute; it will come to me. Not Neuric. You're right. I'll tell you in a minute what it is, but you'll have to know that name. And Asia grade also you'll have to know. What is Asia grading?
Yes. Yeah. Subhanshu, you talk about Asia grade?
Sorry, I think one classification was, I think Tully's classification, if I'm not wrong. That
Tully had used this classification. It's an English name.
Okay.
Is there, do you know any other Tully's class? I don't know Tully's, but there's a...
Singh and Punjabi and then Tully. Na? They both were almost similar. Tully had modified it for his book, I believe. Regarding the functional grading.
No, I'll tell you in a minute. It's in one of my old presentations. I'll pull it out.
Okay. Yeah. So by the meantime, Subhanshu, talk about the Asia grade, why it is, what it is exactly.
Asia grade A, B, C, D, E, where A is total neurological involvement. B is motor B is total motor loss, motor involvement with sensory preserved. C is motor functional present, but I'm not that.
Wrong. So read about the Asia grading. It is very important for the exam, theory as well as practicals. Okay, it's complete, incomplete, okay, Frankel grade A, B, C, D, E, all.
So Frankel is the TB guy, Frankel grading.
Asia grading is must to know. Go ahead.
So I examined the reflexes. Superficial reflexes, abdominal reflex were absent. Cremasteric reflex were absent. Babinski was positive. Hoffman was negative. And deep biceps, upper limb reflexes were normal, while knee jerk and ankle were brisk. On sensory, the fine touch, pain and temperature, joint position, vibration are fine touch and pain and temperature decrease below D8 level. Joint position at grade 2 ankle and knee were absent. Vibration absent or medial malleolar and the sin of tibia, and perianal sensation were present, sir.
Go back to reflexes. How do you check? What are the other superficial reflexes you have not mentioned?
So pertaining all over the CN, all spinal examination.
Yeah. I'm not talking about this case. I'm just in general asking for everyone. Tell me, just talk about abdominal reflex. Tell me about how did you check the abdominal reflex?
Sir, asking the patient to lying in the bed, exposing from nipple to the groin. I stroke with a sharp object from inside to out and see for the contraction of abdominal muscles on that quadrant, sir.
So where did you check exactly? Where did you stroke?
Sir, out from umbilicus to out, sir, in the fourth quadrant.
So you divide into 4 quadrants and then do it. And so what is the significance of abdominal reflex?
Sir, in an upper motor neuron type of lesion, There will be asymmetrical reflex, means abdominal reflex, superficial reflex will be absent, while the deep reflex will be exaggerated.
Superficial and deep, I didn't get it.
Superficial reflex will be absent, sir, in UMN lesions if it is above the D8 cord level, and the deep will be exaggerated, sir.
So proximal and distal, not superficial and deep.
I didn't get it, sir.
Proximal, the proximal two quadrants and distal two quadrants, you mean to say, right?
Yes, sir. Yes, sir.
Yeah. Okay. Fine. And yeah, go ahead. Sir, yeah. Agni sir, anything?
No, nothing. We can move on. Yes.
Sensation fine touch.
Subhanshu, 1 second. This patient was spastic?
Yes, sir.
So how did you elicit spasticity per se?
Sir, checked for the tone of the patient, asking the patient to relax and lie down in the bed, and then bend the knees, both the knees simultaneously, and compare it. But the patient is having a class knife type of spasticity where there was initial resistance, and then the patient was able to, passively patient was able to move.
So then now the next question that follows is, because you said clasp knife, what is the difference between, suppose, spasticity and rigidity here? Can you tell me at least two differences?
So in the class knife type of in a spasticity, it is based on basically it is movement based and a vector speed vector based. So if you increase the speed in a spasticity, you will the spasticity will go away, but in a rigidity you will get a continuous it is not speed dependent first, and you will get a continuous rigidity, continuous increase in the tone with the whole range of motion, sir.
So basically you are trying to say it is velocity dependent spasticity, and that is independent. What is the next one? Another reason, I mean another difference, if you know, I mean just because we are on that topic. So
yeah.
Sir, spasticity is because of the pyramidal tract involvement, while the it is because of the pyramidal.
And just to add to this, any one more point? Just one more. I mean, spasticity is always below the lesion, okay? And rigidity will be generalized, if you ask me. Like,
yes,
if you have a PD, it will be a generalized rigidity. And it is usually lead pipe or cogwheel, where you have a clasp knife spasticity on the other side, okay? Rigidity is lead pipe or cogwheel, and spasticity is clasp knife, okay?
Yes, sir.
Yeah.
Right. And how did you check vibration sense?
Sir, tuning fork, I place the base of the tuning fork over the medial malleolus and shin of the tibia, and to check whether he is able to feel it or not, sir.
From where do you put? From where to where do you do it?
Put over bony prominence, any bony prominence, mostly because the middle malleolus and the ankle, then the shin of the tibia.
Then any other places proximally?
So proximally, you put it on the radial styloid and
No. For lower limb, first you start with the first MTP joint, then come to medial malleolus, then come to shin of the tibia, then come to.
Okay. Yes.
Subhash, I think your connection is a little weaker. Hello.
So anyway, I think basically what we are trying to get to all the students is that neurological examination has to be absolutely thorough. And there's special books, maybe Rohan or someone who's just out can tell us which book to read for neurological examination. But it's so thorough that mostly, once you're out of the exam mode, you will not read it. if anyone has a suggestion, please put it up on the, or just, shout it out loud. So we know what to read for the exam, basically, what neuro examination book.
So Rohan was the guy who actually guided me through my exam. So Rohan, please.
Okay, we'll get to that.
Yeah.
Go ahead.
So DJong is a book which is a very important for your neurological examination. And then our standard medical books, which we used to read for medicine in our UG, PJ Mehta and Kundu are two books which it helped me for my exams.
Okay, go ahead.
Does anyone still read Hoppenfield Neurological Examination?
It's there, sir. I went through it. Yes, it's a very good book.
Yeah, I think it gives a very good insight, and it has got dermatome wise this thing. You can read it in a day or 2 days if you want, but it's a very good book.
And our time there was a Pattison. Pattison was like a star book for us for our MS. But I don't know. So currently, whichever is there, I think go with that.
Yeah.
Okay, go ahead.
Vanshu, you're back. Start.
So my positive findings were deep tenderness present at D6, D7 level, knuckle deformity present at D7 level. There is a hypertonia, sensory level at D8 level, power bilateral grade 3 and below. Abdominal and cremasteric reflex were absent. Deep tendon reflexes were positive below in the both lower limb, and Babinski were positive. Deep tendon reflex were exaggerated.
Right. So can you give us a diagnosis now?
Sir, 18-year-old female patient comes with, my diagnosis would be a progressive extradural compressive thoracic myelopathy, most probably at D6, D7, with bilateral spastic paraparesis, with sensory level at D8, with the most common etiology being infection, and I would like to give my differential as neoplasm.
Points in favor of infection more means what led you to say this is infection?
Sir, starting with the history, the patient has a gradual onset progressive back pain with a weakness and associated with a constitutional symptom like loss of weight, appetite, with night pain and evening rising temperature was there. Also, in the examination, there was a knuckle type of body present at D6, D7 level. Also, the tenderness is much more, and this is a bilateral spastic paraparesis, which is asymmetrical, patchy, and there is a sensory level at D8. So that indirectly suggests it might be an infection.
Subhranshu, when you say neoplasm, so what neoplasms you are thinking in this case?
So the patient is 18-year-old. The most in 18-year-old osteoid osteoma or osteoblastoma or
Will osteoid osteoma cause a neurological weakness?
No, sir. Don't cause the osteoblastoma or aneurysmal bone cyst.
So you are looking
yes,
at primary bone tumors.
Primary bone tumor, yes, sir.
Right. So what other tumors you can think about apart from primary bone tumors in this age group?
Sir, what
other tumors you can think about apart from primary bone tumors in this age group?
I don't know, sir.
Okay, so basically the hematological or lymphogenous tumors, these type of, they can be present in young age.
Ewing's is again common in this age group, 10 to 20.
Sorry, Harshal, what did you say?
Ewing's is also common in this 10 to 20.
Yes. Yeah. So when you say primary bone tumors, you are theoretically covering those. I'm just trying him to expand the neoplasm, what he has.
Neoplasm, yeah.
So Ewing's is there. Then even these hematolymphogenous tumors can present, like leukemias and all. Sometimes they present in younger age and all. They can also present with soft tissue in the in the spine and which can cause a compressive myelopathy or something.
Yes, sir. Subhanshu, when you say differential, you should be able to tackle a few of these questions. So people will not go into great depth of these things, but yeah, you should be able to answer a couple of these questions so that they understand that and you're thinking on those lines.
Yeah. So you should not, means you obviously you didn't say, but something like a trap would be you to try to say a metastasis in this age group.
Yes, sir.
Yeah, carry on. What would you like to do next?
Sir, I would like to confirm my diagnosis by doing a series of investigations, starting with first X-ray and then MRI. X-ray would be X-ray of thoracic spine, anterior, posterior, and lateral view.
Okay. You have the X-ray?
Yes.
If you had a choice of only one investigation, which would that be?
Sir, MRI I would do. It's better to deal in soft tissue and structure.
Okay. So what's the value of X-ray then? In the sequence, why did you mention X-ray?
Sir, to see the amount of bony destruction, it will be better with like X-ray. So the MRI would be the best choice, sir. But
again, this question will always be asked for any pathology in the exam, because in any pathology, MRI is better than X-ray. So once you lost, but so I think we should have a standard answer ready for that. My general answer used to be that the X-ray is easily available. Most easily can happen within minutes. I can get it. I can get a first look at the spine while I'm waiting to plan my next big investigation. And it can delineate some bony and structural anomalies, the balance, etc. I can see the chest, etc. So, I mean, I should have a good answer ready to vomit out, because this question is invariably going to be asked while you go through. And you cannot say that I'm going to ask for an MRI. You'll have to say I'm going to ask for an X-ray. So, you almost are walking into that trap, so you have the answers ready.
Maybe.
And how much percent? Yeah, Agnivesh, go ahead.
Sorry. Go ahead, Aditya. Please ask.
Yeah. How much percent of bony involvement has to be there to be seen on X-ray?
Praveen Gopal Raju, answer this question. Praveen
is exam going?
Yes, he's exam going, sir, from Bombay Hospital.
And Umesh, is the exam going? I can see Umesh, Praveen, Sanjay apna's chiller.
Yes, yeah. Praveen, you're there? It's a very simple question. Umesh, you can answer.
Okay,
answer.
Yeah, he has written on the chat 30 to 40%.
Come on, open up your mouth. 40, no problem.
Sir, 40%, 40 to 50% destruction has to be there to be visible on X-ray.
Around 30 to 40.
You should say decalcification, not destruction.
Yes.
Decalcification. Destruction, even 10% you can see. If your 10% of end plate is gone and the vertebra is collapsed, you will still be able to see it. So the decalcification has to be more than 40-50% so that you can appreciate it compared to a normal bone on an X-ray.
So how much does the X-ray lag behind the MRI in terms of time? Umesh, yourself to answer.
Sir, for the benefit of this thing, and even Maya also, I would like to ask that in exam, should we comment on the chest X-ray when you're thinking of TB, that do a chest X-ray also?
I 100% would say that. And I had in my exam many years ago, I had a TB case and I had said it, and I was asked about the chest X-ray. I was asked if I had auscultated the patient, and I tended to score because of that, because that's a ground where me and the examiner were both on the same level, because even they knew only that much about chest X-ray and about auscultation. So I would encourage yes. And then you need to know what percentage of TB spines actually have pulmonary involvement statistically.
I think I was to ask that question to Subhanshu whether he talked about the chest symptoms, breathlessness, and everything in his negative history, because that is an important thing when you have a TB case.
Right. All right, go ahead. Subhanshu, if you're here, go.
This is an X-ray anterior posterior view and the lateral view of the patient, showing a dorsal and a upper lumbar spine. In the upper thoracic spine, there is a collection on the paraspinal area, and in the lateral spine, between the in the mid dorsal region, there is decrease in the disc space between the D6, D7 vertebra with a localized kyphosis. And there is also some rarefaction of the bone and ragged edges of the end plate at D6, D7 end vertebra.
So Subhanshu, one quick suggestion that whenever you describe a X-ray, choose one film like AP and then start describing it from the center and move outwards so that you don't miss findings. So similarly, like in AP, you first comment about the visualized that you are able to see from D2 to L4 level or L3 level, whatever the levels are visualized. Is there any rotation in the spine? Is there any scoliosis or bend? Then you move laterally and see all the pedicle shadows are visible or they are not visible. Then you move even lateral and then you comment on the soft tissues surrounding the spine. Then you move even lateral and comment on lung field or abdomen if you feel anything. You may have a renal calculi seen on a lumbar X-ray. In lumbar, you have to comment on swath shadows. In dorsal spine X-ray, whatever lung you can see, if you find anything, you comment. If you don't find, you just leave it there. Whatever ribs you can see, you should see. So move from center or one side and go spread out in that way.
For all exam going, this is a very important point. So stick to one X-ray first, finish that, and then move to lateral, as Agnivesh has said. And you can have top to bottom, center to outward, whatever way you want to, but finish one X-ray, and then it will be more methodical. Basically, you'll not get hyper when X-ray is shown at you, and it allows you some time also to think.
Yeah.
Why this X-ray is shown to you. Yeah.
So like in this X-ray, if I see, sorry, let me see if I can find out that draw.
Sir, on AP, can we see that bird's nest kind of a thing which you?
Yeah, yes, that's that bird nest. That's what I said. You can see it very clearly here.
Yeah.
It's a good exam X-ray. And even I wanted to point out that if you see that you can't see a disc between the two vertebrae there.
Exactly.
So you might as well want to mention that this disc I'm not able to sort of visualize.
Okay.
Sir, also one more point, sir.
Can you see this arrow?
Yeah.
Yes, sir. Yes.
Yeah. So maybe that disc is there. So you can mention that part, that this is, we can't see this part of the disc.
Yeah, Rohan sir, you're saying something?
No, I think there's one complete collapse of one vertebra. If you go to the extreme right X-ray on the lateral.
Yeah.
So I think I can see that pedicle there. So I mean, there's the one vertebra is completely collapsed. So he had to talk about that also, because he just spoke about the paradiscal involvement, but he never spoke about a complete, collapse and then increased kyphosis, which he also is supposed to speak on the X-ray itself. I mean, given the fact that there was that X-ray film kept, I mean, whatever is there in your presentation. So I think you can see that pedicle there, but the body is not there. So there is one complete collapse.
Yes.
So about this collapse part, they will ask you about knuckle, gibbous, and rounded kyphosis. That question will come. How many vertebral involvement and all those things will come. Means that kind of question will come to you.
Yes, sir. So knuckle is at if there is only one vertebra level involvement, gibbous if 2 to 3 vertebra involvement, and angular kyphosis if it is more than 3 vertebra involvement, sir. And then there is a rounded kyphosis. The first 3 were in the angular kyphosis.
Right. Yep. Go ahead.
So Subhanshu, describe the lateral X-ray, what you say?
So in the lateral X-ray, there is a complete destruction of D6 vertebra with the upper D5 vertebra lower end plate touching the upper end vertebra of the lower vertebra. There is a slight kyphosis present at D5 and D7 level. There is and yes, sir, that's all.
What about this vertebra below? Does it also look reduced in height?
Yes, sir. No, not reduced, but it's showing wedging.
Wedging. Yes, yes. So you might as well want to mention that. You can say that this vertebra below this is, I think, D11. D11 looks wedged, but without destruction of any end plates or osteopenia.
But is there any significance of that finding?
Sir, wedging of the dorsal vertebra, if it is more, if it is present at 3 consecutive vertebrae, it is significant in Schurman kyphosis, sir.
So that is, you've gone in a very different trajectory, but then it will come to how many degrees and everything for each level. What I'm saying is that for your given diagnosis, is it significant?
So what he's asking is that, is it a single place involvement or looking at a multiple spread or a multiple this involvement?
Yes, sir. It can be due to the involvement of that level of the vertebra also.
So basically, the skip lesions. It can be a skip lesion.
Skip lesion.
So you have to find a gist of a question. You have to get a gist of a question. That's what we are talking about, and then answer that question very specifically. Because each and every examiner will have some or the other thought process. You have to get to that question. What is exactly asking, and give that answer. And it is important finding. So you don't know whether this is a diseased vertebra or not, but pointing it out is very important, as Agnivesh sir rightly said.
Yes, sir.
Go ahead.
Sir, I would like to further investigate the patient in the form of MRI.
Yeah, you have the MRI. Show it.
This is the MRI of the patient in T2 sagittal and T2 axial view. In the T2 whole spine view, there is only one lesion. There is no skip lesion in between D5 and D7 level. In the anterior part of the there is this hyperintensity signal at D5 and D7 vertebra compared to the upper and lower other normal vertebra. There is a hyperintense collection present in the anterior part of these two vertebra. There is an anterior collection present inside the spinal canal, compressing on the spinal cord with significant compression, as we can see in the axial cut. Also, in the axial cut, there is a paraspinal abscess surrounding the two vertebrae in the coronal plane. Left and right, both sides are there. And there is some localized kyphosis present, sir.
Which related lesions will get missed? Skip lesions. When you said there are no skip lesions, there are two areas in the spine which can still be affected in and around the spine, which may be missed on this data that you have on the MRI.
Sir, if the lesion is present at CV junction, cervicovertebral junction, and SI joint, if there is any.
Perfect. Also, whenever you say I'll ask for an MRI scan, the immediate follow-through question will be, what will be the prescription? What will you ask for actually? And then it'll go to what is the percentage of skip lesions in in today's time. Today's time, it's very different from our time because now MRI is more popular. So the incidence of skip lesions has significantly gone up. So I hope you're aware of the stats.
It's 20% now. Before it was less, around 5 to 7%. Sir.
And what is the percentage of pulmonary affection concomitantly?
So 30%.
Yeah, 30 is I think going over, but I think 20 to 25. But you can recheck that. We normally used to say 20 to 25. Okay, cool. So this is pathognomic of tuberculosis.
Yes, sir. This looks like a tuberculosis, but I would like to further confirm my diagnosis.
So on the MRI, tell me 5 things in favor of TB as against pyogenic.
Sir, the destruction of vertebra is the first point. There is not in pyogenic infection. It is more like a spondylodiscitis infection present in the disc. But here the vertebra are destroyed. The collection. Second point is the collection amount of the collection present.
Second point, I'll accept that there's significant amount of soft tissue. The first point, can you clarify again?
Sir, in pyogenic infection, the pathology mostly lie in the disc space. While in tuberculosis, it lies in the end plates. The disc is because of the avascular necrosis of the avascular necrosis, not directly involved.
Okay. So spondylodiscitis is pathognomic of which condition? Spondylodiscitis. What is a classic lesion of tuberculosis?
Sir, paradiscal involvement and plates are involved in tuberculosis. Contagious.
Okay. I think I'll buy that. Any reason why end plates are involved in TB?
So the blood supply are through the epiphyseal arteries, which supplies the end plates, and 2 end plates are supplied by a single artery. That's
Metaphyseal. Epiphyseal is almost done with this time. Metaphyseal arteries. So the arteries. Okay, that's number 2. Number 3. Any other point in favor of TB here? Yeah.
Sir, bony destruction is much more in tuberculosis compared to pyogenic spondylodiscitis.
Okay. So can you tell me the reason why bony destruction is so much more in TB, soft tissue is so much more in TB? Any reason why?
So it is because it is a T cell mediated immunity which the body is fighting against. So try to enclose the infection as much as, and during that procedure the destruction increases. It's not limited.
What is the immunity for pyogenic?
Sir, it is humoral immunity, sir.
And what are the types of T cell immunities? There are 2 types.
It can happen with a killer cell T cells, and it can happen with a macrophages.
There's a name for it. 2 types of T cell. And which other infection does T cell immunity get involved in?
Sir, viral.
Fungal would be a better answer.
Yeah. So I would not like it if you talk about T cell immunity when I ask you about radiology in TB, because it will again, someone who's more intelligent than me will just take you for a really long spin there. Okay, so the basic reason is that tuberculosis is an indolent, slow-growing infection. So by the time presentation happens, a lot of destruction has already happened inside. While pyogenic is a much more quick-acting infection, it's not an indolent, slow infection. So before actual physical destruction happens, the patient gets symptomatic and you land with an MRI scan. That is the basic funda. So a lot of this, destruction, a lot of soft tissue. So MRI looks really bad before the patient actually presents. That's the basic funda.
So if this same question comes to me in exam, or like if we have to answer this question, just mentioning these 3 words, chronic granulomatous infection in TB, would that suffice, or you want a detailed answer for this question which you asked?
Yeah, I mean that's good enough. That's good enough. It's a chronic indolent infection, slow infection. Okay, so T is helper T cell and cytotoxic T cell. I mean, you may as well read it up if you're going to talk about it, because of this COVID and all, there's a lot of charcha about T cell immunity. So and then vitamin D, how that is in directly linked to T cell immunity. So if you want to talk about it, you read up and then get back. All right, go ahead.
Sir, I would like to confirm my diagnosis by doing our CT guided biopsy.
Shubhanshu, before going ahead, sorry to interrupt.
Yes, sir.
One more, the costovertebral involvement, that is also classical of TB. So if you see lesion in the costovertebral level with soft tissue, so that is also classical of TB.
Okay, sir.
So what sir is saying basically is that instead of saying paraspinal involvement, you have to say a paravertebral involvement or a prevertebral involvement, because it has both a subligamentous collection also and a paravertebral collection also. Okay.
Okay, sir.
Yeah.
So how often do you get contrast MRI, sir? Agni sir and Aditya sir, would you want to comment on that point? As a first MRI?
No, I would not get a contrast MRI unless I have a doubt in diagnosis. So my usual prescription is for a plain MRI only. And if I require, I can get contrast sequences done in the second, sort of in a second stage immediately. I have that facility that I can get it done immediately within a few hours if I need to do that.
Yes.
So
Agree with Agnivesh.
Yeah. So first MRI is always a plain MRI.
Yeah.
And the MRI is extremely oversensitive in tuberculosis, and it picks up even inflammation. So if you do a contrast, even a normal MRI can start looking woozy. So in TB, there'll be a lot of pickup, and it will. So the only role of a contrast MRI in early diagnosis of TB is when you're thinking of an epidural or a intracord kind of involvement, where delineation can get difficult. So you sometimes have normal looking MRIs, but you're suspecting, like spinal cord tumor syndrome, etc. Those forms of TB, where you would want to then commit to, intradural presentations. You want to commit to contrast scans.
So even for the intramedullary TB, so you will find something in the plain MRI, and then you give a contrast to sort of.
Totally. But that's the only indication to ask for a contrast early. Otherwise, you rarely ever have to ask for a contrast.
And usually that you get a ring enhancing type of a lesion in a intramedullary type of a TB if you have that.
Yeah, go ahead, Subhanshu. What would you like to do next?
Sir, I would like to repeat the biopsy, and I will consult with the patient's relative regarding the need for the surgical management, because the patient has been on 6 weeks of anti-tubercular treatment as per his history, and she developed a neurological deficit. She is deteriorating, so better to take an open biopsy and simultaneously decompress the cord with the debridement of the neural structure.
Subhanshu, before that, and I would ask this to Agnivesh sir and Abhay sir also. Sir, the role and the importance of CT scan just before, going ahead with the surgery. Do you all always get this done, a CT scan?
So pertinent question, and Subhanshu, you'll have to answer that for the exam. Just to reach out to that question, the first lead question would be that would you ask for a biopsy if you're planning surgery? If you're planning surgery anyway, you better have your answer ready, Subhanshu. As far as once you plan surgery, what is the other investigation that you would do? And it would be wise to mention CT scan, though in practice we don't always ask for it. Rohan, that's a practice colleague discussion. But exam I would definitely say that I would want a CT scan for better bony delineation to plan my surgery. Here, I think most of us are experienced enough in deciding what to do, except in some rare situations, I would not routinely ask for a CT. Subhanshu, what would you ask for a biopsy before surgery? If you're planning surgery?
No, sir. If I am planning for the surgery, it is better to take a sample.
So why did you utter the word when the management came up? Why did you utter the word biopsy as the first word? Exactly. That actually irritates the examiner. So when you want to offer a surgery, whatever you want to offer, give a proper reasoning for that. Your first word when somebody asks you what do you want to do next is biopsy. That should not be the way you should answer.
So here the question will come that in which cases of suspected TB you'll do biopsy, and which cases you will straight away go ahead with surgery. So now the discussion will come to the indications of surgery and which conditions you will just do biopsy.
Also, since this is going to be a standard trap for you, because should you say biopsy or should you say surgery? There should be a standard way of answering it. So I would say that, sir, I would like to confirm my diagnosis with tissue diagnosis. However, this seems like a clear-cut surgical indication to me, and hence I would, go ahead and plan a surgery, counsel a patient for surgery, and get adequate tissue biopsy during the surgery. The examiner will instantly ask you, would your surgical plan change if the biopsy showed something else? So you should have an answer ready, because this is a very clear-cut case and you have to have thought about it before. That supposing this was a cancer or supposing this was a pyogenic, would your surgical plan have changed? So typically not in this case, because there is no role of en bloc excisions here, because this, even if it's a, if it's a tumor, your plan is going to be palliative reconstruction. If it's pyogenic, the plan remains the same. The entire idea of doing surgery is to get neurology on the right side, to reconstruct and get the sagittal balance right. I mean, those are the three things that you want to do, which you'll have to do regardless. So here you have an adequate defense to straight away say surgery, but not without letting the examiner know how you're thinking. So if you say after MRI, I will do surgery, they will hammer you. If you say after MRI, I'll do biopsy, again, they'll hammer you. Because in this particular case, so you have to, and that's your typical exam case, right? You're not going to get just some bony lesion. So you have to have that answer ready to construct and throw at the examiner, anticipate his other questions about when would you change your plan and all that.
Yes.
What are the conditions where biopsy would be critical?
Sir?
In which conditions biopsy would be critical or important? What's sir asking?
A patient who has been on treatment and is not.
Basically, in a condition where there's no role for surgery, in any presentation which is non-surgical, biopsy becomes critical. I mean, that becomes the basic thing. So if this was a bone lesion with pain, but that's not an indication in your book for surgery, then you would ask for a biopsy, isn't it?
Sir, again, there are some specific things which are asked in exam regarding blood investigations. So in such cases, at what time you should talk? Because the moment we finish our case, the first thing that comes to mind is X-ray and MRI. At what juncture we should talk about other investigations, blood and everything?
I think.
How would you want to phrase that answer?
I would say with the X-ray, because they are as non-specific or specific as an X-ray, but they are as important as an X-ray. Like you can't proceed without saying X-ray. That way you can't proceed without saying CBC and whatever basic bloods you want to do. So I don't want to be caught saying MRI before saying basic investigations. I think so.
What I did in my exam was that I said immediately post diagnosis, I said, sir, I would like to get some lab and radiological investigations done. And then examiner asked what lab or what radiology, and then accordingly I answered, because it was an exam, so they put up the X-rays and everything. Yeah. So I think people can find their own ways to answer this question. Agnivesh sir, any points in that?
No, I think I would continue it one line saying that apart from the basic investigations like bloods and X-ray, I would also like to get an MRI.
Yeah, I think that's a fair way of answering. Can we ask is Siddharth exam going, or is Praveen there? Umesh, you can light up your screen so we can continue the discussions. Dr. Arjun is also here.
Hello, Arjun sir.
Praveen and Siddharth, if you can light up, because you're the only three bakras we have for now.
Yeah.
So there's a bunch of people watching on YouTube. I just cross-checked. There's like 2 dozen folks on YouTube right now. So, I mean, the standard question would be pertaining to ESR, pertaining to inflammatory markers and any other specific investigations. So, Praveen, can you tell me the role of IgM, IgG on blood investigation?
Praveen just messaged me, sir. He's in library. He's listening in library, so he cannot talk. So
yeah, but if he can answer online, that's fine. Yeah. Siddharth or Umesh can answer separately.
Umesh, you can unmute and answer.
IgG, IgM. Arjun, yeah, go ahead.
IgG signifies it is an acute process if you do IgG serum test. Yes, sir.
And IgM?
IgM is like an chronic inflammation it's going on.
So if this patient had a positive TB IgG and negative TB IgM, would that give you some specific,
Yes, sir.
versus if it was positive IgG and negative IgG? I mean, does that take you to any diagnosis?
It's a chronic inflammatory kind of thing we can think of, sir. Yeah.
So would you ask for those tests in this case?
Routinely, no, sir. Yeah.
What about TB Gold?
TB Gold, no, sir. We
You ask for
should
a Mantoux test. These have all been banned by the government, so you should not ask and not talk about it because they are very, very non-specific tests. They have nothing in relation to TB, and TB gets misinterpreted in smaller places because TB IgG is positive. So the government has actually asked you not to do them. What about Mantoux test, Umesh? Would you ask for it in this child?
Sir, Mantoux test can be. It's not a confirmatory test, sir.
So in your practice, would you ask for it if you were the treating doctor?
No, sir. Yeah.
And in which specific condition would you ask for a Mantoux test in your practice in India?
So if the child is not presenting with the classical symptoms of tuberculosis and not taken previously BCG also, so we should ask for Mantoux test.
I'd not concur with that.
Yes.
Like, what is the flaw in Mantoux test? Like, why don't we ask routinely for Mantoux test in our population?
So it was kind of endemic this thing, tuberculosis. So it can be positive in many asymptomatic patients.
In like ours, it will be positive regardless of BCG or regardless of your symptoms. So it's not to do with whether your symptoms or whether you've taken BCG. It's just that so basically if it's a foreign national who's presented to you, a Mantoux test will become very, very useful because that person is not from an endemic zone. So and equally important is doing a Mantoux test when you're working in a foreign land which is non-endemic. That's the only truth about Mantoux test.
Yes, sir.
Arjun, any question? Any information, Arjun, that you want to share about TB?
So I think Subhanshu's presented really well. I was kind of quietly listening. Yeah, I was quietly listening to him and all the questions. He was grilled by all of you. So I mean, about the labs, I think it's important to ask, Subhanshu, what are the labs which you'll ask for routinely?
Sir, blood counts, CBC, complete blood counts, ESR and CRP. In blood counts, we specifically check for the absolute lymphocyte counts and the level of ESR and CRP to prognosticate whether the treatment is working or not, sir.
Apart from that, what else? What are the tests that you usually will ask for in all tuberculosis patients who you're planning treatment or already on treatment? What other tests are mandatory?
So we will get done HIV also since it might cause immunocompression and might be the cause of the disease. Also the liver function tests, sir, before starting the treatment because the anti-tubercular drugs are more hepatotoxic.
Right. So the liver function has to be done at baseline. You'll ask for it, and even if the patient is on AKT, you will ask for it. Every couple of months. The HIV, as you correctly said, because it's for an immunocompromised patient, and Dr. Nene attributed. We discussed about T-cell immunity. He also talked about the Mantoux test. So the Mantoux test, if it's depressed and the patient has tuberculosis, remember the patient can be immunocompromised. It's about the T-cell immunity. You have to keep that in mind. Okay.
Yes, sir.
But I think you should mention the labs probably, quickly because it needs to be sort of discussed. And traditional examiner may prefer that you talk about the labs earlier, before you ask for an MRI also. So, right.
Okay, right. So, Subhanshu, you talked about, are you there, Subhanshu? Not able to.
Yes, sir. Yes, sir.
So, then what would be the management now? You would offer the patient surgery.
Yes, sir.
What would be the goals of your surgery?
The goal will be the debridement of the dead necrotic tissue, decompression of the spinal cord, and then stabilization of the body.
What is the first priority goal? If you prioritize, I want to do 1, 2, 3. What is the first priority in this case?
The decompression would be the first priority.
Okay. Second priority?
Then stabilization, sir.
Okay. Third priority?
And debridement of the necrotic tissue. Dead and necrotic.
What do you gain by debriding the necrotic tissue?
So first for the to decompress the sorry, we have done it.
So again, here the goals are absolutely standard. There's no two things. It is decompression, first neural elements. Second is biopsy, enough sample. So, that's the second. The third is stabilization. Fourth is reconstruction. These have to be your goals. Removal of necrotic tissue has got no role, barring that it gives you tissue for biopsy, and barring that that's the way you decompress the tissues. So, mentioning that you want to send tissue for all the samples is very, very high up on your list.
Yes, sir.
Okay. Would you do a anterior surgery, posterior surgery, etc.? What's your plan here?
Yes, sir. All posterior surgery, sir, with 2 level above and 2 level below fixation, sir.
Why not anterior?
So we can do an anterior surgery, but with posterior, all the goals can be achieved easily, and anterior are associated with its own complications.
So one reason why you would not do anterior surgery here. Can you do it here? If I said anterior, is it incorrect?
So we can do it.
So why did you not want to do it? What is your reasoning not to do anterior as your first option?
Sir, with anterior, we can directly address the disease part, but the stabilization would be better with the posterior.
Yeah. So you always answer, instead of giving the point answer, give the thought process, because you are not sure what the examiner wants. There's some examiners who may want to do anterior here. So it's always a good idea to weigh the two things in front of him when there's a question that has no direct 100% answer. So you say that this could be done from the front or from the back. The advantage of doing from the front are blah, blah, blah. Advantage of doing from the back are blah, blah, blah. I would choose back because of blah, blah, blah. Got it? If you answer in that way, there's very little room to doubt your thinking. You're not just sitting on one horse and riding it. You're trying to, evaluate all the options in front of you. That's what I would expect you to do, because this is a spine surgeon discussion, not a MS exam discussion. Okay. So now with that in mind, can you answer my question?
Sir, with the advantage associated with the anterior decompression is the direct addressal of the disease. Without handling the cord, you can decompress. There won't be much handling of the cord. Second, the disadvantage with the stabilization is not good. And while doing an anterior deconstruction, you tend to produce a more defect, which is difficult to fill up. The advantage of posterior is all the goals of our surgery will be achieved with the posterior approach. The stabilization will be good, and the kyphostic correction will be good with the posterior because of the long lever arms. However, the disadvantage is it is an indirect type of decompression where you are not able to visualize directly. Other than that,
so the most optimum way would be
so anterior plus posterior, sir.
Posterior plus anterior. So the ideal would be that you reconstruct and instrument stabilize from the back and decompress and tissue biopsy from the front. So you're not crossing the line. But that can be a cumbersome approach. And today I've in my unit or in my training, I've learned how to go around the cord effectively. And hence I would prefer a posterior approach. You can say that all posterior approach, but the principle of TB surgery is that all stabilization and instrumentation from the back and decompression from the front. That is the principle. Whether you have access front from the back is your decision.
Okay.
Is that okay?
Yes, sir.
All right. Anything else, other examiners?
I mean, so just to continue Abhay sir's talk right now, what are the ways in which you can access the front from the back, Sudhanshu? What are the portals that you have from behind that you can go in front?
Sir, we can do a transfascial decompression.
Okay.
We can do a transpedicular decompression.
And?
We can do a costotransfectomy.
Okay.
When would you do a transpedicular versus a transfacet approach?
Sir, if the lesion has involved more vertebral body, then it is better to do a transpedicular approach. And if it is the lesion is more in the disc space, then the transfacetal approach will be a better option.
What about rib resection? When would you resect ribs?
Sir, if we want an anterior reconstruction of the vertebral body loss, we want more space to introduce a cage or a structural graft, bone graft between the bony ends. That time we need to excise the bones, ribs.
Okay. If you do, yeah, yes, someone was asking.
For anterior reconstruction, what will be your choice? Cage or bone graft? And if bone graft, which one?
So bone graft will be a most biological one because we want a fusion in the anterior part. So a structural bone graft with the help of ribs, or if the defect is a large, then fibula can be used.
Okay, and so in which conditions you will put cages?
Sir, we can put cages in place of a structural bone graft if the structural graft is not adequate enough.
Adequate enough is the reason for putting a cage?
No, sir.
Then tell that there's a significant morbidity associated with harvesting a bone graft, and it sometimes involve a separate incision or something like that. Then that's why we go ahead with the cages. Anything else you want to add, sir?
What would you send the tissue for? What all would you send the tissue for? Can you give us a prescription for that?
The tissue will be sent in 2 sample bottle, one with a saline, with a formalin. The saline one will be sent for the AFB, then ZN, AFB stain, ZN stain, gene expert, TBMGIT, fungal culture, and routine culture and sensitivity. And while
what do you mean routine culture?
Sir, routine culture means if there is any pyogenic element to it, then it needs to be cultured.
So specify what cultures?
Related to tuberculosis?
In any sample, you don't know what is tuberculosis or not. What cultures? Aerobic?
Aerobic and anaerobic. Aerobic, sir, not anaerobic.
Yeah, so if you want to send for anaerobic, what you should be prepared with?
So the medium should be present in the OT so that it can be inoculated directly.
So in exam, when you utter a word anaerobic, you should be able to answer this question. Yeah.
And a saline bottle for the histopathological examination.
Saline for histopathological.
Sorry, formalin. Sorry.
Why not saline?
Sir, formalin helps in maintaining the integrity of the tissue, sir. When the saline, it doesn't.
So what will happen with saline?
Sir, it will start decomposing.
So it will lyse the tissue. The tissue will become
Like the
edematous
cells,
and it will
yeah.
lyse.
Again, fungal culture will send.
Yes.
Anything else you want? What is the difference between Gene Expert and Gene Expert Ultra?
So Gene Expert is a rapid polymerase chain type of PCR type of test where the presence of dead Mycobacterium bacilli can be assessed. Along with that, rifampicin sensitivity is assessed. While in Gene Expert Plus, other than rifampicin resistance, you can assess NH resistance, fluoroquinolones, and
Read it up. There's a other difference.
Yes, sir.
Read it up. Gene Expert and Gene Expert Ultra. In which cases we send Gene Expert Ultra specifically? You would be able to answer that question also.
Intraoperatively, if you get only you can say the infected granulation or only infected bony tissue, with those tissues, will you be able to carry out Gene Expert?
Yes, sir. We can try, sir.
Because most of the times they say that if tissue is like semi-liquid or it's liquefied pus-like thing, the yield of the Gene Expert is a lot more better compared, means obviously they can carry out that test, but the yield of the Gene Expert, the possibility of getting it positive, it's more if sample is liquefied. So if you get abscess, chances of getting Gene Expert positivity is a bit more.
Okay.
Finally, what will be your TB regimen, anti-TB regimen for this patient?
Sir, for this patient, 2 months of intensive phase, including isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by the course of HRE, isoniazid, rifampicin, and ethambutol for next 8 months. Next 10 months, sir. We generally give tuberculosis treatment for 12 months.
And what is the dose of each?
Sir, isoniazid is 5 mg per kg of body weight. Rifampicin 10 mg per kg of body weight. Pyrazinamide 25 to 30 mg per kg of body weight. And ethambutol 15 mg per kg and streptomycin 15 mg per kg.
And when do you give streptomycin?
Sir, in MDR cases, multiple drug resistant cases, the treatment involve adding one injectable antibiotic. That time we can add streptomycin.
But that is not streptomycin. That's normally kanamycin or something else, because streptomycin still falls in the first line drugs. So there's almost no indication of giving streptomycin, even in people who have INH. So if you have INH resistance, what does that mean?
The patient has patient has a multiple drug resistance.
No, that's wrong. 30% of Indians are inherently INH resistant. So if you have INH resistant, you don't still get just solitary INH resistance. You don't get classified as MDR. If you have rifampicin resistance, you get classified as MDR. If you have INH resistance, the general protocol is to add a ofloxacin or a moxifloxacin or a ciprofloxacin as a primary line drug. That's the only indication to do to start primary line floxacins. Okay, which are the bactericidal drugs amongst the ones you mentioned, and which are the bacteriostatic drugs?
Sir, isoniazid and rifampicin are bactericidal drugs, while ethambutol and pyrazinamide are the bacteriostatic drugs.
Is the indication for surgery in MDR TB different?
No, sir.
Is the outcome of surgery in MDR-TB different?
Outcome, I don't
Think and say no. You're answering well.
Sir, in MDR-TB, there is more destruction of the vertebra compared to a normal tuberculosis.
No, wrong. Basically, the outcome is the same if the drug treatment is managed well. So the only reason why the outcome can be bad is the delay in diagnosis and delay in getting cultures. Like there's a medical problem, not a surgical problem. Got it?
Yes, sir.
Like medically being MDR, you sometimes don't get the culture. So you're giving wrong medicines for long. So you have a worse outcome. But if you have everything tight, then it's the same outcome. Ditto for HIV, ditto for diabetes, everything. Okay, so I think I'm good with my questions. Anyone else? I think it's a well done case, Subhanshu. Well presented, and you kind of wrapped it up nicely. I think I'm happy to see you getting more and more vocal and confident in the last, 2-3 presentations. And I'd encourage the other guys to also present, because the key here is to be able to speak the examiner's mind. Like Subhanshu and me are together with each other every day for the last 2 years, and yet over here I'm asking him, questions from a very different angle. So just imagine when an outside examiner is going to ask you questions, you're going to get totally flummoxed. That high pressure is there in front of you, and this guy is like staring at your eyes and asking you a very simple question. And hence the knowledge is one thing, but actually execution and how to actually handle the exam is a very, very different thing. And that involves presentation. Like all the time, keep presenting, keep getting into the thick of things, getting whacked. And that's the only way, because, mostly if, being an examiner myself, I can tell you this, at least in the ASSI, we are assessing the common sense of the guy. We are not assessing deep intelligence. We are assessing whether he's safe enough to go out and, take care of spine patients. Or is he going to have a brilliant theoretical knowledge, but say something absolutely ridiculous and, get a PET scan for this case? Then I'm not going to, he may know everything about a PET scan, but I'm not going to sell him I'm not going to give him the ASSI degree if he's going to say PET scan in this case, for example. Okay, so answering common sense, staying on the straight and narrow path, and leading the examiner to the way you want the discussion is what the crux of an ASSI exit exam is. So I think well done, Subhanshu. Any other concluding remarks from the faculty?
Just want to ask one question more, sir.
Absolutely.
Yeah. Sir.
Subhanshu, what is line probe assay?
Line probe assay is, sir, one of the rapid detection, one of the investigation to rapidly detect the tuberculosis. However, it takes around 2 to 3 days for the detection, and it detects the alive bacilli and needs to be a smear positive result with, and it also detects resistance to rifampicin, INH, fluoroquinolones, and
Nice. Yeah. Here, smear positivity is main thing, because in Gene Expert, the smear is negative. Means it detects rifampicin resistance in smear negative sample. So here, the smear is positive and gives a resistance pattern against rifampicin and INH.
Yeah. So the principle of Gene Expert is that nucleic acid amplification test. And here in LPA, we look for the smear positive, as sir said, and we also look for sensitivity for multiple drugs. Arjun sir, anything to add? Sir, you are muted, sir. You are muted.
I think you presented very well, and I think you answered also very well. So. Just one last question. What are the surgical indications in spinal tuberculosis?
The surgical indications involves a progressive neurological deficit. If it is functional, grade 3 or less than grade 3, then even if after taking conservative line of management for 6 weeks, the patient is not improving, or a new onset of neurological deficit appears, in a pediatric patient, especially in pediatric, third point is in pediatric patient, because of the instability and chances of higher progression. Third is to get a good amount of sample biopsy collections, if we are not able to get it. So these are the main indications for the surgery, sir.
spinal instability also. You know, in
Yes.
adult patient, spinal instability also becomes, you know, the patient who has no neurology, but who is continuing to have severe pain and instability, you know, which is not responding to a treatment with the brace and AKT. All right, that would also be.
Yes. Sir, I have one question, sir. Since this is an adult case, the Rajashekaran sign of spine at risks, and it won't be applied for this case.
No, this is not. That is not valid here.
Not yes.
But there is a spinal instability scoring. You know, it's recently published.
Oh, okay.
Sir, anything to add?
No, nothing from my side. Very well presented, Subhranshu.
Perfect. Then I think we can. I think it was well timed and nicely done.
Yes, sir.
And you will announce the next session whenever it's set, no?
Yeah, it's next Friday for sure. Next Friday, 8 to 10 p.m. We are having a short case presentation and a lecture on scoliosis. So 1 hour session on scoliosis and a short case presentation.
Perfect.
Yes, sir.
All right, Arjun, thank you so much. Agnivesh, thank you so much. Aditya, thank you so much. And Rohan is here. Thank you, Rohan, for for taking out the time, because it's invaluable for the students and for the multitude of people who are going to go through that OrthoTV, the recording. People have been coming back with very good comments, and they are very happy that we're doing this. And please continue to be involved in this, because it's a matter of a few more weeks before the exams come up. So we look forward to your contribution. OrthoTV, thank you so much for helping us go to the masses. And of course, Harshal, thank you for the heavy lifting.
Thank you, sir. Thank you so much, sir. And again, this is a very important topic for your theory as well as practicals. And discussion here was just a superficial discussion. We can go into depth of everything, from clinical examination to history taking, every single symptom to investigations. You should be thorough with TB, because if you can't flunk in TB is bread and butter for us that way for exams. So definitely read all those points which the esteemed faculty talked about. And be prepared for exams. For TB is a very definite case for your exam. At least 1 or 2 guys in your exam will have a TB case. Yeah. Perfect, sir. Thank you so much, sir. So the next session is on next Friday, 8 to 10 p.m. And I'll announce all the details in the group. Thank you, sir.
Thank you, sir.
Thank you. Bye.